Thank you. And it's great to have seen all of you. I know many of you are off camera now as you eat your lunch while we chat. Um, I do use pronouns she, her. I'm really open to anything. If we're having a conversation, that's something I'm just really pleased to do. Um, I work for Cancer Care Alberta. I am a nurse. In terms of my background, I also did further work in health promotion with a social justice focus. Growing up in Scarborough, Ontario, I think it's with a social work for a dad and a mom in public health is kind of baked in to my worldview, and really important, I think, for all of us in healthcare. We're doing amazing things for lots of patients, and we just need to make sure that those amazing things are accessible to everyone. I'm just going to share my slides, and here we go. So just give a wave that you can see them. When you were doing introductions, I did do a bit of work to make some notes to make sure I um, covered things I want to share with you. But please, let's just be informal. Happy to answer questions. I have been immersed in this work probably for about a year and a half or 2 years, but it really is about making applicable learning available to frontline cancer care staff in really manageable bites. Here we go. So just to give you some background, as I mentioned, I'm part of Cancer Care Alberta, and Cancer Care Alberta provides care to adults, so 18 and up, but we will see people diagnosed at 17 because they're just about to enter the adult system. We have 17 cancer centers across Alberta. Two of them are tertiary centers, which means they really have comprehensive, cutting edge and the full spectrum of care. And then we have four regional centers, which offer, you know, a wide range of systemic and radiation therapy. And then we have community cancer centers where people can get some of the systemic treatments as close to home as possible. Some people with cancer get their treatment outside of cancer care in specialty centers, say in Calgary and Edmonton. But really, for those people, even the supportive care services, so things like psychology, social work, education, they are accessible to people, even if they aren't getting care in cancer centers. Within that context, we work with lots of partners, and certainly over the last 6 years, and there's been a commitment that predates the last 6 years, but over the last 6 years, working with CPAC grants, CCA has been strengthening their commitment, furthering their commitment, growing their commitment to strengthening Indigenous cancer care together with partners. So through the Canadian Partnership Against Cancer, between 2019 and 2023, Cancer Care Alberta worked very closely with many Indigenous community government leadership partners in order to do two things. One is to take some actions. How can we strengthen Indigenous cancer care together? And the second was to create this action plan that looked at, what are things we need to focus on? What can we do to achieve that First Nations, Métis, and Inuit people are diagnosed as early as possible, that they feel safer and welcome at cancer centers, that they're highly satisfied with the cancer care they receive, and that Indigenous people are completing cancer treatment and having survival rates consistent with those of non-Indigenous people. And the areas of action, this is just kind of a summary of the entire document, but the document and commitment was published in June of 2023. And it really is these four interconnected areas of action. And I can certainly share a link to the document. Relationality is kind of central and related to all aspects of care. But in the work we're talking about today, fostering safer, welcoming, and supportive cancer care environments is sort of where this work is grounded. And as we were working with partners talking about their experience in cancer centers, but also at that time, with the new cancer center in Calgary coming on, we had the chance to be really practically focused in a cancer center and what we could do so that when we open and beyond opening, we're being safer and welcoming and supportive. And what was very clear in the conversations, it's about the physical space and it's about the people who provide care in that space, which is our staff primarily and volunteers and so on. You might already guess what this slide is all about, but in cancer care and in Indigenous communities, there are many priorities and a constant evolution of demands and learning. With cancer care, we're always getting on new treatments and having to learn what we need to know to provide those treatments to ensure patients have the information they need to make informed decisions and then to keep people safe as they go through care. And so that context is really where we're entering in terms of trying to foster knowledge, whether it's strengthening people's understanding or through kind of reiterating or reinforcing things they know, or through adding knowledge and adding options. So in terms of, sorry, I'm going to go back here. When we set out following that action plan in our current cycle of practice, we knew that getting information to frontline staff and to cancer care as a whole was really important. That the culture change of how we work and really the way we deliver care impacts people's ability to get care in cancer care. So equity can be, those broader socially determined health, but it's also system structures and the way we provide care that impacts people's ability to access and succeed in care. And so we started out doing things like lunch and learns, and we definitely were bringing in elders, bringing in people with experience who were embedded and working in community, First Nations community health centers, the Otipemisiwak government, doing through rounds where a lot of staff do try to prioritize getting to rounds. And then we did a survey in 2024 to just get a sense of where staff were at. And it was very clear that over 50% of our frontline staff, people who are interacting with patients regularly, were not being able to access those education sessions. They weren't accessing Indigenous resources that are on our external and internal websites. And so we had to really think about what we were doing and how we could do it differently in order to meet our objective of really reaching frontline staff. And so what we did was to work with managers at one of our cancer centers to really talk about the issue. We had those results. And sorry, I'm going to ask you, Tara. Yes, you had your
Yeah, I
hand up.
was just curious if you got a sense of like why people weren't able to access the existing resources. Was it a time thing, or did they not know where to find them, or or maybe that wasn't part of your survey?
Yeah, we did have some responses that gave us some information. So there's sort of two things. One is in terms of those ability to attend a rounds or a
Right.
session that's online. Frontline staff are often working in cross coverage,
Yeah.
and the only time they get to sit is during lunch. So it isn't always a priority. They don't have access to a designated computer, for example. So for virtual rounds to hop on and get access to those. And then in terms of resources, it's an ongoing process through training to make people not only aware of sort of the clinical practices, but the resources that people can access. And with the turnover in staff, just supporting them to find them. And then the third thing is people um, even knowing when a patient is Indigenous and then feeling able
Right.
to share information, how they have those conversations. So we, in many ways in these microlearnings, we try to address multiple of those, but first by reaching staff with education.
Yeah, I do.
Yeah, for sure. And please, everybody, I love that. A hand up is great. And if I miss a hand up and you see it, please just come off mute and bring it into the conversation. So in working with, we were able to take survey results to the managers of one of our large tertiary centers. We were engaged with them around some different conversations. And really, one of the things they brought forward is there are spaces when we meet monthly or weekly in team huddles, team meetings, and that it would be optimal if information could be shared in that space. And that really it needs to be something we can take on as a portion of what might be a half hour to an hour meeting. So the other thing they said is sometimes people aren't able to be in those meetings, whether they're on vacation. So not only do they want something they can deliver to staff live together, but also that can be caught up on by individual staff after the fact. So my boss came back and said, we're going to design learnings that are 15 minutes or less. And so we sort of set out to figure that out. My scan at the time of like micro learnings is a term that definitely was around then, but they often referred to, an hour as a micro learning compared to a webinar. And we were very committed to this 15-minute time frame. So together we kind of looked at that, looked at the literature, and then just really brainstormed what we needed to put in order to, sort of have the chance of success. So it was important that it was short. We settled on that 15 minutes because even if a meeting was a half an hour, it would fit in there and any updates they had to do the team. We knew it needed to be flexible, so we went with an online forum with the idea that it's easy for managers to access, but also easy for staff to access on their own. Interactivity and action-oriented, again, to make it meaningful to staff, to kind of heighten their engagement and their motivation. And then connecting to existing expertise. So there's so much amazing information, education, knowledge out there. We didn't want to be duplicating something. We wanted to give people a connectivity to the subject matter, to some things they could do themselves, and then really introduce them to strong sources of information that they could then further explore themselves. And then through the course of designing, it sort of emerged that we were also doing two things. One was working with a lo-fi, and it'll be interesting as you look at these, a lo-fi design, which really came out of this. There's so much information and so much flashy content and so much that in some ways this feeling of sort of being a calming effect or a not escalating effect on the nervous system when people were engaging with the learning. And then getting beyond the brain alone, and in Indigenous space, I don't think this would be a surprise to anybody, but really trying to engage with the heart as well as the brain to, I think, and I'll say it in my own way, when you're engaged, like as a nurse, it's often about what I think and what I know and what I have to apply, but it can also become, there's sort of a numbing to the actual impact that has in the world on people, what they're going through when it sticks just in the brain. So trying to look at that, that's how I think about it, but moving beyond the brain to engage staff in the learning. So I'm just going to give you a few examples. If we talk about interactive and action-oriented, what does that look like? So these are some of the slides that you would see, and the modules are developed in Articulate. They are sort of slide-based, and then you click to forward. So true and false, that's one of the ways, facts that people or might sort of know about, for example, cancer rates in First Nations, but they don't know details. And so trying to find facts that will sort of escalate people's importance of the topic. This is another one. So we're talking about spaces, and this one was to try to give people a sense of what it is to be in a scary place and have a lack of control. So this slide comes up, it joins the entire screen, so it's almost all dark blue. And the next and back buttons are not available for, I can't remember, 3 to 5 seconds. So again, how do I get out of here? How do I move on? Which people may register consciously or unconsciously, but it takes people through a series of thinking about a scary place and then imagining you're forced to get your cancer care in that space. Sorry, I'm mixing up my buttons. And then at the end of this what section, again, trying to connect people to experience, there's always a reflection slide, which is about just considering the past content, hopefully discussing it in the context of your team, but also taking the time to reflect as an individual if you've gone through it alone. And at a recent cancer education conference in Toronto, well, it's probably a year and a half or 2 years ago now, in the equity space, they were talking about the kind of primary leading shift in education is really around critical reflection, to think about who's missing, who's not, to really ask yourselves questions. So we use that principle in terms of furthering I'm sorry, I'm getting the back and forward mixed up, people's ability to enter into and heighten the importance of the topic, so that when they moved into the so what section, which is about what can someone do in their personal daily practice, they were ready to think about, they felt it was important to consider taking action. And so there's different ways of doing it, but we do in the different modules, but we certainly look at usually more than one kinds of actions people can take. Again, it's a frontline staff in a patient interaction context. And so they usually are, 3, 4, 5 options. And people then select which option do I want to unpack and explore. So each of those blue bars, they have to click all of them before they get the option to move on. But as they click each one, it gives them an explanation of what that means and what that can look like in practice. And then now what offers encouragement to try those, to revisit it with your team and talk about what you're learning, but also for people who want to learn more, it gives them space to go to learn more. And in both the embedding of existing content and the suggestions we make, either as content in a slide, as a link to a slide, or as a link to future learning, we tried very much to look at Indigenous voices, Alberta work, and then Canadian work. So again, the context would be really relevant. So if we look at, for example, the slide on the right, the yellow slide, these are a series of videos that were created through a grant in BC, Alberta, Saskatchewan, and the Northwest Territories. And it's people who have faced cancer, either as family members or patients, and then cancer care providers responding, talking about different topics. So this one specifically talks about traditional practices and the value of traditional knowledge to Indigenous people's cancer care. It does have clinicians reflecting, which I think is really important for our own providers to see kind of other providers entering into the consideration and the support of different things. And then there's a whole series that people can access. We've also linked things like Equip for Equity, which comes out of BC and offers a lot of amazing tools. So in one of the modules specifically, we link to that. And the idea is they try one tool, but explore the toolbox broadly. We link to and offer people the chance to view a portion of Unforgiven, which is a film with individual sections. It's hosted by the Canadian Medical Association, but it's created by Indigenous peoples. Very powerful, strengths-based both gives some of the context, but also some of the ways in which Indigenous people are growing health in that context of what they've been through. And the idea is really to plant seeds. In 15 minutes, we hope to plant a seed that will grow, that includes some real concrete potential actions and some trusted ways of learning more if people choose to. Every module, in terms of functionally what they look like, includes a title. So the title, we usually start with the topic and we work through it so that the title, if someone only ever saw the title, would hopefully send a message that is meaningful and again is a seed. So CCA is committed to strengthening Indigenous cancer care in Alberta. Now I, as a CCA staff member, understand that there's some sort of commitment. Whether I go further, maybe I'm going to ask someone, but hopefully I dive into that. Two, in the bottom corner is the back and next buttons. So we do sort of disable them if there is an action we need someone to take, but we sort of support staff to take, to move at the pace that they would like to. Three, on the left, we developed this what, so what, now what, and made sure that people could move back and forth between them as a way of building importance, confidence, and then opportunity. And then four is the content, which is sometimes it's just information. Sometimes there's links. Sometimes it's this interactive kind of question and answer. It can be video. We did a series where we have scenarios and you kind of use buttons to find out more about the scenario. And then five is resources. So if we're linking to documents, the resource will have those links in there. So anywhere in the module, you can access those. And then at the end, you can access them before you leave. And in some of them, there are PDFs people can take away. And when I mention Equip, for example, then there would be a link to Equip in that module. So we're getting close to the end of my presentation, but we developed these slides and we have to ask ourselves, are they useful, right? We were trying to make a useful product, but how do we know if it is useful? So with that in mind, throughout the development, we, one, used an iterative development process. We, two, made sure to test with our manager partners to see if they could actually felt they functioned for them in team meetings. And then we also have a user experience survey in each of the modules. So the iterative development process, we, in our work with community partners, with elders, through our ability to have some focused effort, we certainly heard many things that it's important that cancer care staff understand and that healthcare staff really understand and meet Indigenous patients with. So we had a lot of that information. We also have a lot of partners. So even Aaron talked about the work here in Alberta for that intake conversation. And so we have a number of teams in the equity space, in the Indigenous space. And so sometimes on a specific module, we would get together to try to identify the way we wanted to go about it and what were some of the key pieces of information. And we have worked with some external partners for ideas, but also for development, and recognizing that there are external partners who don't have a lot of money for staff education and development who are interested in accessing these. And then, of course, we go through, as a core team might develop, we go through a back and forth where people look at the module, provide suggestions. That includes Indigenous partners. And in finalizing, we have a sharing circle that includes Métis and First Nations partners from around the province. And they are always given modules to review before, and then we have a final internal sort of executive leader reviewer who reviews it from a CCA perspective. In terms of the experience yes, we'll keep going. So this slide in the right is just to reflect that through the iterative development and the testing with managers, we would get feedback and we would make those changes. And the software we're working in enables us to do this. So this is just a slide that was added. It's in every module, but people have the option to look at it or not, because as they move through modules, they will be familiar with this. So they don't need it every time. But it really supports people in how they can approach the module together, particularly. And so there were a number of things we did like that as we developed, and then we're able to apply across sort of our approach to the modules. So this just reflects the review. So the software we use has a number of different elements, and one of them is review. So Articulate Review allows us to load a microlearning module, and then anybody we send the link to can look at it. So every partner, they don't have to be within the organization, can have a look, and as they look at a slide, they can then add a comment. And as they add comments, if Erin's reviewing and Tara's reviewing and Gabrielle's reviewing, you will see each other's comments as well so that you can respond to them. I think that's a great idea. I was thinking this, or you don't have to repeat comments. And then when I, as the builder, goes in, I can look at those comments and I can check them off. So then they disappear once I've addressed them, but there is a record, so that if any time I needed to go back and look at kind of how we work through things, that's available to me as well. And then the way we've made the modules live, so for anybody who's worked with sort of these interactive learnings, AHS and CCA, we've become our own organization in the last year with the AHS, or the Alberta Health System reorganization, but we still use the same learning platform. But they use often people are loading them into learning platforms, which require, they offer things, but they also require a password to enter them. And usually, well, for us, we have to have a CCA or an AHS ID. We have to be part of that system. But even if we made it available externally, it means people have to sign up to another app, which is becoming a fatigue. And it does kind of add to the manager's burden to get this to their teams. So we are looking at how to make these available outside of a password access learning platform. And there are a couple of reasons for that. I'll speak to the other in a moment. But in this system, we can actually turn off comments. It remains in review, but people can see it and use it just like a normal learning module, but they access it with a single click. So it's wonderful. And as long as they're accessing it that way, and we have it in review, if somebody identifies an issue, or so the Métis Nation of Alberta 2 years ago voted and became the Otipemisiwak government. So we could adjust to that change in minutes. So I can actually, if I'm aware or somebody makes me aware, I can go in, make the changes, and then load it up. The link stays the same. Unless you're in the module, you wouldn't even know something had happened. And then the next person who sees it, the information is correct. So there's a lot of benefit to working in that space. And then the question, is it useful? We do have this survey, and what we recognize, we do when the survey is filled out, it says, did you do this as a group? Did you do this individually? All the responses that we had gotten as of a couple of months ago when I last looked at it in depth, I did look at it recently, but is that everybody who fills it out is doing it individually, which is not surprising. It makes sense. We did add a QR code for the evaluation, so staff doing it in a group could access it that way. But right now it's all people doing it individually. And for all of those, was it easy to understand? Was it easy to use? 100% response that yes, people agree with that statement. And then in terms of people being able to learn something and apply it to work, everyone agreed again with the statement, but one person out of the respondents said they somewhat agreed. And so I think just a little less strength in terms of their ability to apply it to work. But as a whole, it is working in terms of people able to use it and find it applicable. So we now have a total of 7 microlearning modules that are live, and I'll just let you look through the titles. I'll stop talking in a moment here. Yeah, why don't you read through them quickly? We are adding a module that was in the works around, we have Indigenous cancer patient navigators that are available to support patients and to support staff as they work with Indigenous patients. We've actually, since starting the module, added another Indigenous cancer patient navigator position within CCA, and we've had the incredible I won't say fortune, it's been a lot of hard work by a lot of people over 3 years to get 2 Indigenous cultural liaison positions. And so those 2 positions have just recently been staffed. And so we're just reworking that module to be about both navigation and cultural liaisons. So the timing is perfect. And then um, have started work on a 9th module that would just kind of tie it together and sort of synthesize um, the work. I think there's always opportunity for more topics, but 2 things are happening. One, we're coming to the end of a fiscal year. And 2, we really need to do some focus work on spreading the word, getting it out to people. And that's where our current really, building is a piece of work, but our current sort of um, need to figure things out is around the permanent digital home. Optimally, I think it would be optimal if we could host it on our external web. I think it's valuable for us to be transparent with Indigenous people in the province, all of our partners, that they can see what we're teaching and offer suggestions, criticism, access, and use the modules as they want to. And then we also need in this space, if we think back to that radar picture, how we're going to routinely promote the course, review, update, and ensure accountability. And that means for us working within our network of clinical education, web maintenance, um, management, and so on to figure that out together. If I will, Tara and I were talking already, I will share a 1-pager. It's PDF with links to all of those modules. But in the meantime, if you are interested, you're welcome to scan the QR codes. I will say that 2 is CCA's commitment. 4 is trauma and violence informed care is safer care. And 5 is Métis distinct resources are available to support patients or Métis patients. Sorry, I can't remember the title. But you're welcome. You should be able to scan those and open up a module and look at it yourself. That's it for me.
Thank you so very much, Krista. That is, I'm just really impressed and grateful for the work that's gone into this. And I agree that the more publicly accessible this can be, the better for the reasons that you shared. But also, I think that, um, these will probably be very useful beyond Alberta, maybe some more than others because some are very context specific. And that we don't need to reinvent the wheel in every province or in every center that through collaboration, we can advance this work. So thank you so much for sharing that with us. We've got 14 minutes for questions. If anyone has a question, feel free to just unmute and ask your question or share it in the chat or whatever you would like to do. Perhaps, does anyone want to start? And if not, I can ask a question.
I actually was really into the topic and I really loved the presentation and the entire work that has gone behind this. And as Krista spoke, I had a few questions and, something to learn more and understand more. So first thing was that, when you were talking about the moving beyond the brain, in one of the slides, I wanted to know if it was for the staff engagement purposes or just for the modules or anything that went into the module and was talking about the staff and patient engagement.
So just to clarify, you're asking where that comes from or where the intention is?
Where the intention is, yeah.
Yeah, I think the intention, and I open it to others to comment. So certainly in the space of working with Indigenous communities and partners, we often start out meetings or conversations in a way that kind of, I think, grounds us, but also gets us, like, for me, I find it connects me on a more than a kind of intellectual way. That can also be through stories or different things. In work I do, that's health change with, sort of behavior change, health change work. Again, increasing importance can help people move to action. And again, I don't know the literature here, so I look to anybody else. But often, again, I find in myself and in the work with Indigenous people and with others that there's kind of we're so brain oriented that there's sort of a habitualness. I know that, but do I know that? And so the idea is to help people move into a space, the learner, where there's kind of a more of a openness, a more of a connectedness to the content. So if anybody's looking for research, all my work is about implementation in the cancer context. I'm not a researcher, so others comments. I don't know what to say more than that.
I think it actually makes sense to me, but the only detail that I wanted to learn more was about was this approach being implemented in the modules for the staff to understand the purpose, how we could move beyond brains in terms of interacting with the patients. Is that what the intent is?
The intent is to open the person, the learner, up to be able to sort of engage in action, for it to be meaningful to them.
Sounds good. Thank you so much. And then when you were talking about 15 minutes for the modules, so I don't know if I got it right, but was it the 15 minutes for each module, like you had 1 to 8, so 15 minutes for each module? That's right, right?
Yeah.
Okay. And is it like you've pilots tested it, and is it lively available for anyone external to use right now? And that's how we got those 15 responses.
It's been shared with staff in various ways. So I am anybody can, of course. So I will share the links, but they are not, for example, sitting on our external web right now. So there's no concern about people accessing them, but there has to be some way you get access to them, whether I share and then you share with someone else. Yeah.
So you were talking about one module being reworked on. So I saw that there were 1 to 8, but 6 was missing. So I wondered if that's the one.
That's the one.
Okay. Gotcha. And one last question. So you said that you're working on the ninth one right now, and I was wondering if these modules are like ongoing ones, and in the future, would we have more modules being added to them as needed?
I think there's nothing to limit that. I think reconciliation is very important, and Indigenous people have some of the worst health outcomes in cancer care, and the greatest challenges to overcome entering into cancer care treatment. And there are a number of people where we need to really look at how we can be more equitable, more supportive to helping them overcome barriers. And so the modules themselves are Indigenous focused, but have a root of equity. And so a number again of the actions. So trauma and violence informed care is safer care. I mean, really, if we use that as a universal precaution in healthcare language, we would provide better care because we don't know who is undergoing violence at home, right? We don't know who has experienced sexual violence growing up. There's many things we don't know. There's many people that we know may not feel as safe as someone, like myself as a white woman healthcare provider. A hospital is like a second home to me, although I might be afraid or I might, you know, but it's a lot harder for a lot of people to enter. So I'm thinking, and Erin might want to chime in, if we looked at more micro learning modules, we might expand kind of the lenses of equity and connect. But we haven't really discussed that. There's no closed door. Erin?
Yeah, like I think what we're finding, like just with the work I'm doing with the intake assessment, and we're just going into a pilot where we're interested to see how it helps us to open the conversation to Indigenous people identifying to healthcare providers that that they are Indigenous and they need that support. So I think these micro learning modules will be really valuable for the province because I think that conversation is just going to get opened up more and to be able to let healthcare providers come in with a lens where we're open to helping support people that, this could be a very vulnerable place for them. Yeah, the more information, the better. So I'm really interested to see what our pilot's going to show in the next couple of months and how we can tap into those resources. And we're actually going to be like sharing them with our staff that are doing the pilot up in Grand Prairie so that they haven't spoken to patients a lot. So I think it's going to be really valuable for them to reflect on their own experiences that, a lot of these people have worked with patients for many, many years, but that doesn't mean there's no opportunity to change our focus or maybe just how we speak differently to people or how we, address a certain topic because now we're thinking more with that lens that maybe somebody finds this a really intimidating place to come. So, yeah, I think there's lots of opportunity and, Krista, I think you should do research on this. Like, I think you should be a research nurse now. You said you're not, but like Tara said, like a nurse can be a researcher. That's fine.
Absolutely. Well, and I think we are so fortunate to be a learning organization, and the way these modules are built enables us to be responsive. So I think, again, we may see some evolution in the modules based on the experience in Grand Prairie, where they have one of the largest percentage of patients are Indigenous. So again, it's just super exciting. And Erin and I will be having a few more meetings too.
I also really like how, we heard 2 months ago from Erin and then today from you that the work is very complementary and there's, been attention to um, the supports perhaps needed to have the most robust response. I don't know if I'm making sense, but I guess an example would be like in your oh, I can't remember what you're calling it, Erin, but the needs assessment um project, it's like, okay, great, we've, identified these needs, but we've done really nothing to support the providers in their own learning or comfort or ability to respond. But these are a component of building that capacity, um, and something that becomes quite accessible. I see we have one question, so I'll give the last question to Yinka.
Hi, good morning. My name is Yinka, and I'm with the African Cancer Support Group. I'm also a volunteer with AHS. I just wanted to know, is this learning modules geared towards different communities, or just I know you mentioned that the Grand Prairie, they have a high population of the indigenous group. So do we have any of the learning geared towards the African and the Black communities? Thank you.
Hi, Yinka. It's so wonderful to get your question and to hear from you. Before just recently retiring, I reported to Deb Allett.
Oh, okay.
Yeah. So right now, and I'd be very interested, Yinka, I will send to Tara the one pager and you can look at the modules yourself. They are focused on Indigenous cancer health, but I think some of the modules, some of the suggestions may apply, and I think we are open to possibilities, although of course we always have to figure out how we're going to take on the next incredible opportunity. But I'd be really interested in your review, Yinka.
Okay, no problem. Thank you.
I know you're busy, so don't feel pressure to rush.
How do you know? How do you know I'm busy? Anyway, so just send it to me and then we'll see.
Perfect. And I just wanted to add, Tara, that I think, the other thing that as we do these projects, one of the big strengths is those staff who are working in our cancer centers who have a passion or who have developed skills that we also learn from when we pilot with them, when we test with them, and then that is part of the really critical iterative development to make it meaningful to frontline staff.
Absolutely.
And leverage those strengths and
Yeah.
experiences.
I 100% agree. And I deeply value those working in the clinical space because they bring that perspective of how this is actually going to be taken up and how it can be made the most meaningful. And on the flip side, I have many memories and experiences of being a clinician and being told, well, this is now the way we're going to do things, without that opportunity to provide the context and the perspective of folks working in providing direct patient care. So huge thank you, Krista. This work is fantastic. I'm so excited. There's my timer. It's 1 o'clock. Thank you everyone for joining us. We will be sending out the one pager and the links in our next newsletter, as well as a link to this recording. So thank you so much and hope to see you again in April.